Is a very topical subject nowadays because we are obviously living in a time of great change with a lot of different therapeutic options that we can offer our patients with aortic valve disease. So with that introduction, I would like to start with our first speaker. Before I do that though, I just would like to please remind you who are watching this webinar that you can submit questions online at any time. We will be doing the 3 presentations with a couple of short questions between each presentation. And then this will be followed up by a much longer interactive panel discussion where I will be able to address your questions in more detail. So once again, please submit your questions online and then we will get to them later in the program. Our third speaker is Marco Di Eusanio, who will be speaking about evidence from established and new treatment options in aortic valve disease.
Thank you, Michael. Good evening, ladies and gentlemen. There is no doubt that the introduction of transcatheter aortic valve interventions by expanding the options of treatment for patients with aortic valve stenosis has represented one of the most important progress for our specialty. So with more options of treatment to offer on the one hand, and with an increasingly complex patients population on the other, heart teams operating in heart valve centers become fundamental to identify, propose, and eventually perform the best operation in individual patients. TAVI, thanks to its incessant technical and technological progress, is showing favorable and improving results in different risk categories, and now is focusing on new targets, expanding their indication to lower risk patients, to younger patients, to asymptomatic patients, and also to be able to treat specific challenging anatomical conditions like a bicuspid aortic valve, like native aortic regurgitation and failed surgical bioprosthesis. But parallel to this extraordinary escalation of TAVI, TAVI has revolutionized the standard criteria for the evaluation of an interventional procedure. Correct or wrong, reduced trauma, rapid recovery, and quality of life immediately after the procedure have become important, fundamental key elements when choosing between surgical AVR and TAVI. So I think that surgeons should better listen to their patients and better understand their new requests by expanding the use of minimally invasive approaches. In fact, there are consistent data, multiple studies showing that mini AVR is a better operation compared to standard AVR because it is associated with multiple clinical benefits like less blood loss, less blood product consumption, less renal failure, less respiratory complication, less wound complication, less atrial fibrillation and pain. But unfortunately, there are no data showing that mini AVR is better than standard AVR in terms of major clinical endpoints like mortality, like stroke, like dialysis. And this is likely a good explanation for the less than expected dissemination that mini AVR has shown in the last 10 years. But I think this is also a very good reason for surgeons to improve their own operation, to enrich it by using latest techniques on related to valve prosthesis, to extracorporeal circulation, and to anesthetic protocols. This is a review and meta-analysis study showing that sutureless and rapid deployment valves are able to minimize the duration of cross-clamp and CPB times that I remember represent the strongest predictors of mortality and morbidity in cardiac surgery. This is a randomized multicenter trial with Edwards and Elite from Michael and others showing that rapid deployment valve, a better valve than standard valve, suture valve, in terms of hemodynamics because they are associated with less transvalvular gradients and a less patient prosthesis mismatch. Also, this is a review meta-analysis study showing the increasing use of sutureless and rapid deployment valves during minimally invasive AR, a finding that echoes how minimally invasive surgeons are embracing this technology because this technology is able to simplify the implantation of the valve when working through narrow working space. So I think these 3 observations are very important and make sutureless and rapid deployment valve the gold standard valves for surgical AVR. And And these are the results, the first results from the sutureless AVR International Registry that we had the opportunity to present at the last EACTS meeting in Vienna. This is the largest worldwide registry, an independent registry led and run by surgeons, looking at outcomes after surgical AVR using any type of sutureless and rapid deployment valves. And you see that despite the increased risk of our study population, results were very favorable, with an overall mortality of 1.4% and a mortality of 0.8 and 0.5% in isolated AVR at low and very low risk. Also, early results revealed improvement of results in terms of pacemaker implantation trends, which was just 2% in the last 2 years of the study period, and also in terms of mild aortic regurgitation, which was about 5% in the last 2 years of the study period. But also we can improve our operation and enrich it with the latest technologies with extracorporeal circulation. Minimally invasive extracorporation system have shown to minimize systemic inflammatory response and provide better end organ protection. We believe that MIAC, together with minimized incision, together with the rapid deployment valves, may further maximize clinical benefits of our mini AVR intervention, and for sure they can facilitate the application of fast-track anesthetic protocols with table extubation, with very early and aggressive rehabilitation programs that can start already in the ICU and that are aiming to have patients ambulating already within the first 24 hours of surgery. So we're trying in our institution in Ancona to improve clinical outcomes, but also to increase comfort and fasten patients' recovery, because these are very clear requests for our patients nowadays. So I think that our minimal invasive AVR should go beyond reduced incision. I think that the surgical fight, mini sternotomy versus mini thoracotomy, is quite sterile because results are very similar with the two approaches. So we should look at somewhere else and involve latest valve and CPB technologies and promote multidisciplinary teamwork. Surgeons should not work on their own in the OR, but in a closer and more productive relationship with the anesthesiologist, with the perfusionist, nurses and physiotherapists, because this is so important when working in all patients, but especially in elderly high-risk patients. In younger patients, challenging decision-making more often refer to repair versus replacement issue. And when replacement has to be performed, the choice of the valve substitute becomes crucial. The execution of valve repair intervention is expanding thanks to better understanding of mechanisms of aortic insufficiency, but the anatomical scenario of the regurgitant aortic valve remain highly complex. And if we look at data from the German Society of Thoracic and Cardiovascular Surgery and the data from the STS database, we see that valve repair represents only 1% of all aortic valve procedures in Germany, and that valve sparing root replacement intervention represent only 14% of all root surgery in Germany. Advantages are very clear from valve repair: the low risk of valve prosthesis related events, the possibility to preserve the normal function of the root complex, but these are more technical, these are more complex intervention, less reproducible. In specialized centers, outcomes can be extremely good in terms of short-term mortality, long-term mortality, and also in terms of freedom from valve reoperation. But it is important, I think, to note that given the extreme anatomic variability of the anatomy of the regurgitant aortic valves, and also the experience that is required when treating these patients, data about valve repair are very difficult to interpret in literature. I don't think that valve repair is so far a standardized operation, so I think that we all agree that if we have a patient for whom valve repair is a feasible option, this patient should be referred and sent to experienced surgeons working in centers of excellence. The Ross procedure is another option for young patients requiring an AVR. Hemodynamics, excellent, potential for growth, very low rate of valve-related complication, improved valve durability compared to tissue valves. But when we look at STS data, we see that between 1994 and 2010, the Ross procedure represented less than 0.5% of all AVR procedures. And the outcomes analysis revealed that Ross procedure was associated with increased morbidity and mortality risk compared to standard AVR. This is not always like that. This is not like that in specialized centers that can report very excellent results. This is a study comparing Ross procedure versus mechanical AVR in a very young patient population. Mean follow-up was 14%, and you clearly see that the Ross procedure was associated with more favorable freedom from cardiac and valve-related mortality and with less major morbidity at 25 years follow-up time. The author concluded that in specialized center, the Ross intervention is an excellent intervention for young and middle-aged patients undergoing AVR. It remains that Ross procedure is not even mentioned in the latest European guidelines, and it represents a 2B recommendation in the American guidelines. So in most of cases, in young patients, the choice remains between mechanical and biological valve. This is not an easy choice, not at all, and should be based on data on both valves, on survival, on risk of major bleeding and thromboembolic events, risk of reintervention. We should think about restriction of the lifestyle and patient preference. Current data suggests that there is no difference or very little difference in terms of survival at 15 years between mechanical and biological valve. These are two studies reporting this finding in patients with an age between 50 and 70 years, the middle-aged patients, and patients younger than 50 years. So in the absence of a survival benefit redirects decision-making towards quality of life consideration and towards the risk of major morbidity. And this is a study showing and confirming the patient dissatisfaction for mechanical valves. This study is showing that factors like valve sound and anticoagulation affect well-being stronger than the certainty of a reoperation with tissue valve. And what about major morbidity? This is a study showing that at 15 years, mechanical and biological valves were associated with a similar risk of stroke. Mechanical valve did better than biological in terms of reoperation at the expense of a major bleeding rate. The mortality at 30 days after major bleeding was about 13%, while mortality after reoperation approached 9%. Of note, the reintervention rate after mechanical valve was approaching 7%. But I think that this data should be considered in perspective. In fact, while there is a little hope that major bleeding will decrease in the future, on the other side, I see that the need for reoperation will likely decrease, and also the relative risk of the reoperation in terms of death and morbidity after the operation will decrease. This is a study showing excellent valve durability of the Carpentier-Edwards pericardial valve at 25 years. The freedom from reoperation for SVD was 96% at 10 years, and it was 99, 95, and 90% for patients aged more than 70 years, with an age between 60 and 70 and less than 60 years respectively. So if valve durability is already excellent for all patients and also for the young patient, it is possible that novel integrity preservation technology like the one that transformed the bovine pericardial in Resilia tissue will add a lot in terms of longevity of tissue valves. There are some long-term safety and effectiveness trials that are assessing long-term results. Reoperation is no longer a predictor of mortality. In Center of Excellence, mortality for open redo surgery ranges between 2 and 5%. More than reintervention itself, it's the clinical condition of the patient, preoperative clinical condition, left ventricle ejection fraction to influence the final outcome. And then we have alternative, less invasive transcatheter intervention like valve-in-valve that can be used depending on the risk of reoperation and the type and size of prosthesis. Excellent technical success and satisfactory and improving short and mid-term results are supporting the increasing use of tissue valve in young patients, but one should not forget this is not a good option. This is not good operation when patients are coming with small biological valve, as demonstrated by the VIVID registry showing an increased mortality at follow-up in patients coming with a valve size less than 25 or 21. Well, keeping in mind the limitation of these interventions, there is no doubt that this technology will continue to grow and to impact on surgical choices, on the selection of valve type, favoring biological valves, as we mentioned before, and also on the selection of the surgical technique, favoring annular enlargement operation. It's important that as surgeons we implant the largest biological valve we can if we want to have an effective valve-in-valve procedure later on. So the choice of a mechanical versus a biological valve is not easy. Age should not be overstressed in this setting. The decision should come out of an integration of several factors, and the desire of the informed patient certainly have a central position. Mechanical prostheses are favored in patients younger than 60 years and biological valve in patients older than 65. So we have a gray zone of 5 years, which is even larger according to the American guidelines. The gray zone is between 50 and 70 years of age. For these patients, it is reasonable to individualize the choice of either a mechanical or a bioprosthetic valve prosthesis on the basis of the individual patient factors and preference. It remains that patients are deciding their own valves. When we look at trends in the use of different valves, mechanical and biological, we see an amazing increase of biological valves, and this is happening for all age group, especially the younger one. This is very interesting, I think, to note that this major change has occurred without strong evidence at support, and it is very likely that it will continue in this direction. So I go to my conclusion. One is for mini AVR, the latest techniques and technologies including minimal invasive incision, rapid deployment of sutureless valve, minimal invasive extracorporeal circulation are separately associated with encouraging results. Their use, possibly in combination, should be encouraged in patients undergoing surgical AVR to improve outcomes and increase general satisfaction. Mechanical versus biological valve. Current data suggests there is little or no difference in patients' survival between mechanical and biological valve at 10, 15 years. We don't have data for longer follow-up. Patients with mechanical valve have more bleeding, while biological valve are associated with more reintervention. It is very likely that the rate of reintervention will decrease thanks to improved valve durability and will be associated with better outcomes thanks to improving outcomes with open surgery and valve-in-valve technology. The informed patient choice is most important factor in deciding which valve to use. It remains that biological valves are increasingly favored by patients. Valve repair and Ross intervention are associated with excellent outcomes in specialized centers. Thank you.
Thanks very much, Marco, for an excellent summary. You've published extensively on minimal invasive aortic valve replacement. As you've shown, there's a lot of benefits that have been demonstrated in multiple retrospective studies and a few handful of randomized trials, and yet the prevalence of minimal invasive operations remains disappointingly low amongst the cardiac surgery community. What do you think are the main barriers at the surgeon level and at the hospital level to adoption of these approaches?
Yeah, probably surgical AVR is the simplest operation that as surgeons we are performing. So everything that is making a simple operation a little bit more complex probably is not very well received by surgeons. Probably this is one reason. The second one is that probably there are no data, as I mentioned earlier, that are showing a survival benefit from mini AVR compared to standard AVR. So this is not pushing probably mini AVR a lot. But I think that we should surpass these barriers. We should go forward and perform minimal invasive AVR as much as possible, because I think that patients now are clearly requiring a less invasive operation, a less traumatic operation. It's amazing to see how patients, and I'm talking about TAVI versus AVR, how so often they prefer the certainty of a fast recovery to the certainty of a durable result, for instance. So, but we should receive that, we should understand that, and as a surgeon, when performing surgical AVR, we should do our best to be really minimal invasive. And fast-track anesthesia is one way of doing that. Fast-track anesthesia failed 10 years ago. Why? Because patients were different. They were not focused on fast recovery because there was no possibility at that time. TAVI was not present at that time. That was not a request for the patient. Now, things have changed. Things have changed dramatically. So as surgeons, we should understand this and do our best to make this patient recover earlier. And this is one way to do it.
Yeah, I have to say, there's the surgeons that don't want to adopt these techniques constantly, question the science of the papers, or they point to the papers that didn't show a difference between minimal invasive and standard conventional surgery. But as far as I know, nobody's ever published a paper showing that minimal invasive surgery has worse results, that you compromise patient safety or efficacy. And therefore, my philosophy is, if you can do it just as well as through a sternotomy, then it behooves us to try to minimize the amount of trauma for the patient and try to speed up their recovery.
I fully agree. Safety is the same, but we have a lot of minor advantages from minimally invasive AVR. Wound complication is not a minor issue, I think. For instance.
One more quick question. In Italy, you are a little more restrictive in your TAVI use than we are in Germany. As you know, in Germany, we're well over 50% of TAVIs now. UK is even more restrictive. But do you see minimal invasive with a rapid deployment or sutureless valve as a viable alternative to TAVI in intermediate risk patients?
I think it's a very good, in intermediate patient, I think is competitive. It's still surgery, so it's less accepted by the patient or by doctors that are referring patient to the surgeon. But I think it's still a very, it's an excellent option because the valve is a surgical valve. So you have a perfect result at the end of the operation. And if you are minimally invasive, if you can do this operation through a 4-centimeter incision, using very short clamp time, using minimally invasive extracorporeal circulation, giving only 2 hours of anesthesia to your patient, then I think this operation becomes quite competitive in the low risk or intermediate patient. It's very nice to go to the family and say, after the end of the operation, that the operation was done, that the patient is extubated, neurologically intact, and in 1 hour time the family can see the patient in the ICU, if that is an open ICU. So I think it might be competitive. I'm not sure it will win the game, but it's competitive.
It's an interesting trial. I sure hope somebody does it. Patient 48 years old, they want to avoid Coumadin, they want a biological valve, but they have a smallish annulus. Do you try to do some sort of aortic annular enlargement procedure in order to get a 25 valve in, or what are your decision-making processes in that case?
Yes, I think that with the development of valve-in-valve intervention and technologies, there is and there will be more and more a renaissance of the annulus enlargement that a few years ago was seen as an intervention carrying higher risk, probably not necessary in the vast majority of patients, but now that we have valve-in-valve intervention, it's very important that we implant the largest valve we can. So if we deal with this patient with a small aortic annulus, techniques for annulus enlargement becoming more important, I think. Yeah, so that should be something that we should consider as well. Yeah.
Do you take into
if the patients want a biological valve, otherwise, at the age of 45 years, I think mechanical valve is an excellent solution. Excellent.
There's no doubt about it. The mechanical valve is an excellent option.
Yes.
But a lot of patients don't want to go down that route. Do you take into consideration the new Inspiris valve that you can enlarge the frame later on if a valve-in-valve is required? You know, having said that, this is theoretical. It's never been done in a human, and we have to wait and see. But from an engineering point of view, it certainly looks feasible. We
have implanted a few already in Ancona, 45 years old patients, more or less. That's a good opportunity. The durability is expected to be longer and higher with this pericardium, residual pericardium, and then there is the possibility to implant a larger valve. So this is something that this is an important option that we have to consider when choosing between different valves.
Olaf, did you want to comment?
On the other hand, I think one also should keep in mind that it's not only important to implant big valves to prepare the case for TAVI in the future, but I mean, we have talked for a long, long time about patient prosthesis mismatch in the past, and it has taken a lot of time to convince the surgical community in particular to make them accept the fact that actually patient prosthesis mismatch is something which affects patient outcomes. So from that point of view, I think it should be done, but in addition, also, if you implant, the younger patients are where you implant biological valves, the more important it is that you prepare for the next step of treatment in the future. Absolutely.
This procedure can be done very well in centers of excellence or centers with a particular focus on that operation, but it's not commonly done in many centers. Do you think that the new generations of bioprosthetic valves or bioprosthetic valves that can be enlarged in the future make the Ross operation sort of obsolete, or does the lack of long-term follow-up on these newer generation bioprosthesis with excellent hemodynamics still act as a relative break and say, hey, we need to keep doing the Ross and we need to wait and see what the longer-term data shows?
Well, the Ross procedure is very rarely performed today. Only very specialized centers. This operation is a more complex operation. It carries a higher mortality. I think even in the hands of a Ross surgeon, the Ross procedure has a higher mortality than a standard AVR. So I think this is something that we should really keep in mind. Also, long-term data. I heard the surgeon saying that he was proposing the Ross because that would have been associated with 20 years freedom from re-intervention, but I'm not sure the data are like that in literature. The data from the Dutch and German registry are showing a freedom from re-intervention on the autograft, about 94% at 13 or 14 years, so that is better than tissue valves, but it's not 20 years of freedom that you're giving to a patient. On the other hand, as you mentioned, durability of tissue valves is expected to improve. So I think that I don't think that the Ross intervention will expand its indication in the future. But it's good that there are surgeons still doing that, because in some cases that's a very good intervention.
I think particularly in the congenital group of patients, it is a great operation because it is one of the few valves you can implant which actually adapt to the growing of the patient to a certain degree. So I think there it has its place and it will maintain its place, I'm pretty sure. On the other hand, I agree, in patients who have the opportunity to have long durability bioprosthesis as a substitute, it's maybe less of a viable option nowadays. Also, if one thinks about failure of a Ross procedure, is not as easily treated, for example, in terms of valve implantation, as you can treat failure of a bioprosthesis. That may also will come into consideration, particularly in the older the patients cohort above 50 years of age. So I agree, it has a different kind of value than it had 30 years ago, when it was more often performed because there were less of biological valve prosthesis, good biological valve prosthesis available.
Olaf, I wanted to ask you about that last patient vignette because that was very interesting and stimulated some discussion between us. Very young woman, drug addict, comes in with a prosthetic valve endocarditis, and now in cardiogenic shock, not able to really be consented appropriately. What would you lean towards in that situation, a bioprosthetic valve or a mechanical valve? Let's say, for example, the patient's family members are not reachable, or she has no more contact with her family.
Yeah, I think there are two challenges with this patient. The one is that it is endocarditis, which is a challenging issue in itself, and the other issue is that she came in cardiogenic shock and therefore was not consentable in a normal way, and it seems that it was not possible to discuss them with anyone else, the different kind of options of valve replacement. I would have made a different decision in that moment, and the reason would have been that I would have based clearly only on my own decision about valve replacement in the situation of endocarditis in someone where I am not 100% certain about the extent of the endocarditis and the embolization which has taken place. And often, as we know, there is a lot of silent cerebral embolization taking place as well. So for that reason, and for the fact that she is a drug abuser, she had a complication of her continuous drug abuse after her first surgery with prosthetic valve endocarditis. That's the reason why I would have said she has a risk of complication or endocoagulation after the operation. She has a compliance issue because she had repeat endocarditis after her first surgery already. That's the reason why I personally would have decided for a biological valve replacement, because she had prosthetic endocarditis with an abscess, and therefore it was more a complex type of surgery. I think I would have decided to replace the aortic root with a biological kind of conduit, like a homograft or like a stentless valve prosthesis.
Yeah, when you're thinking about the possible drawbacks of a biological valve compared to a mechanical valve, you're talking about a long time in the future. Your data showed the mean, until 50% of the patients had valve failure was 17 years, and those patients under 60. Which I always find that interesting. Whenever I ask a medical student how long a biological valve lasts, they say, 7 to 10 years. And I'm like, well, actually, no. That's significantly
But I believe that
underestimated.
hasn't changed since the times when we have studied, because we learned that it takes 8 to 10 years until the biological valve fails. And I think the medical education has not adapted to the improvement of biological valves we have seen in the last 20 years.
But in this sort of case, with this person in cardiogenic shock, redo surgery, extensive damage, you shouldn't really be thinking about 20-year results. You should really be thinking about 20-hour results and just getting a survivor,
yes, I agree.
getting them out of the hospital.
If you think about the in-hospital mortality of patients with endocarditis, which is reported between 10 and 20%, you clearly need to deal with the acute issue more importantly than with the long-term issue. And therefore, I think if you get them out of the cardiogenic shock, out of the septic situation, that is more important than anything else. But in addition, I also think if you have someone with a potential compliance issue because of drug abuse, then I think a biological valve is easier to handle afterwards.
Raphael, the discussion really comes down to patients in the elective situation, trading off a risk of reoperation for the bioprosthetic valve versus complications of anticoagulation for the mechanical valve. Do you think that this is, with these newer generation of valves and this more and more focus on valve-in-valve with good results, do you think that mechanical valves are going to become obsolete, or do you still see this playing a very important role in the future?
I think at the present time, mechanical valves still have an important role. Looking into the future is always difficult. Niels Bohr said predictions are very difficult, in particular when they're about the future. Nevertheless, the improvements are taking place, so I would assume that there will be progress in tissue preparations. I think there will be improvements in terms of durability of biological valves at one point, pushing the mechanical valves in the sideline. We're not there yet. Valve procedures will obviously have a place, will expand the role with increasing experience, probably also technological advances taking place, but at the present time we cannot predict exactly what will happen with the current technologies that we use for valve-in-valve, so we cannot say this is the solution for everything, in particular if the initial bioprosthesis is small. Anatomical considerations may lead to difficulties implanting a valve-in-valve, so it is not the solution for everything. And in terms of evolution of different prostheses, we have seen drawbacks, well thought concepts that had drawbacks in the future. So I think we have to be very careful, but overall I see an improvement, and I'm optimistic that the durability will improve. And I think, for example, the Resilia tissue looks very promising of what we've seen from the data that were just presented.
Yeah, it'll be very interesting to see what the future holds. We've overshot our time by a couple of minutes, and I would just like to thank once again Marco Di Eusanio, Raphael Roshenek, and Olaf Wendler, our expert panel. And as you can see from the discussion, There has been tremendous improvement, tremendous expansion of the therapeutic options that we have available for patients with aortic valve disease. And certainly there's going to be a lot of interesting discussions and a lot of interesting studies to come in the future that will hopefully shed even more light on this area. So on behalf of Edwards Life Sciences and my co-hosts, thank you very much, and we hope to see you again. Take care.